Okay, so for this lecture, we're going to go over psoriasiform reaction patterns. We'll start out with a clinical example of a plaque-type psoriasis. So everybody training in dermatology is going to be able to recognize this right off the bat. You have a thick salmon-colored plaque with this kind of silvery micaceous scale on top, very well demarcated. Unfortunately, there are a lot of mimickers of psoriasis. So if you see this clinically for a first-time new patient, it's often good to go ahead and just get a biopsy for proof before putting them on a biologic. Sometimes chronic spongiatic dermatitis or lichen simplex chronicus can mimic psoriasis, and you can even have sarcoidosis, syphilis, lots of different entities, mycosis fungoides. There's so many different types of rashes that can look psoriasiform, at least clinically. So even though we can recognize classic psoriasis, we still have to have some suspicion of mimickers. So how do we think about psoriasis in terms of histology? So what you're going to see in the stratum corneum classically in untreated psoriasis is a confluent perikeratosis. Collection of neutrophils is absolutely key for classic untreated psoriasis, and Monroe microabscesses, which are a collection of neutrophils in the epidermis. The epidermis also contains a diminished or even absent granular layer, and this is pretty diffuse across the specimen in classic untreated psoriasis again, and this is what we're referring to when we're talking about psoriasis, because treated psoriasis can lack some of these features and make it a little bit more complicated to interpret. So an absence of a granular layer is classic, but if you've got some granular layer coming back in treated psoriasis, you have to take that into account. Collections of neutrophils in the stratum corneum should also make you think about the possibility of a fungal infection. So you should definitely always do a fungal stain and maybe a KOH in clinic if you want to make sure that it's not fungal. But biopsy, by that time, they've already done the KOH and it's negative, or they just didn't do a KOH. So it's important to get GMS on all of these. Spongiform pustules of Cajode are also in the epidermis, located a little bit deeper. And regular psoriasiform epidermal hyperplasia is going to show that there's a deeper extension of the reedy ridges, more so than you'll even see in chronic spongiotic, and you'll see pictures of this. The reedy ridges take on a club shape pattern, and that's going to be your classic appearance. In the papillary dermis, you're going to look for suprapapillary plate thinning, and we'll show examples of this. Now, the Auspitz sign is when you can actually scrape a psoriasis plaque and you'll get pinpoint bleeding in those areas where the epidermis was very thin and the dermal blood vessels were easily exposed to the exterior environment and resulting in bleeding. Dilated and tortuous papillary dermal vessels are also classic in untreated psoriasis. So here is a pretty typical example of psoriasis. So you've got that confluent perikeratosis, abundant neutrophils in the stratum corneum. You have suprapapillary plate thinning here, as you can see, as evidenced by where I'm moving the arrow. Spongiform pustules. So again, you're going to see neutrophils forming the Monroe's microabscesses and the spongiform pustules of Cajode. You're going to see the club-shaped reedy ridges, so it really does take on this club shape. And the dermal papilla inversely also have kind of a normal width to them. This is in contrast to prurigo nodularis, where I feel that usually the reedy ridges kind of come to a point. The dermal papilla come to a point here, whereas the dermal papilla in psoriasis are more evenly inversely club shaped there. So just some subtle clues, but this is untreated. Now, unfortunately, in treated psoriasis, you have actually a thinner perikeratosis. You might lack some neutrophils. You might start getting areas of granular layer back. And so it can look a lot like chronic spongiotic dermatitis, unfortunately. The other thing is, if you see a lot of eosinophils in the dermis, that should help you argue against a classic psoriasis and put you more in the atopic / exanthematous spongiosis category. If you see a large lack of eosinophils, you're looking really hard, you can't find any, and it looks like more psoriasiform, then that argues more towards a psoriasiform dermatitis, potentially partially treated psoriasis. More examples of that confluent perikeratosis and collection of neutrophils in the stratum corneum with papillary plate thinning and dilated capillaries and regular psoriasiform epidermal hyperplasia. These are just to give you visual examples. Now, here you see that the lumen of the vessels directly abut the basement membrane. So when I see this, I'll put this in the comment just so that way the clinicians, if they read the comment, they can visualize why I'm thinking about a psoriasiform dermatitis with these types of vessels here. Now, it can be sometimes difficult because prurigo nodularis can also have some dilated vessels here, but the way that it directly abuts the basement membrane and then with that very thin suprapapillary plate and then the neutrophils in the stratum corneum, putting it all together with the hypogranulosis, but you can see here there is still some retention of granular there. So putting everything together holistically with the clinical as well, that's how we're able to arrive at our diagnosis. Now, sometimes if we don't have enough clinical information, we have to be clear that we see both features of spongiosis and psoriasis or psoriasiform. So we have to be clear about what we're seeing and how it could represent both entities. Now, if there's a lack of eosinophils, again, as I said, it helps push us more towards classic psoriasis. But if there's a lot of eosinophils, it'll push you more towards spongiotic. That being said, just because you don't see eosinophils doesn't mean that it's not a spongiotic process. So you can't 100% rely on eosinophils. And there is a drug-induced type of psoriasis called TNF-alpha inhibitor-induced psoriasis, where it's been shown that there are more eosinophils in that entity. So as anything in medicine has exceptions, you should know the classic because that's what they're going to teach you. But in real life, understand there are exceptions, and that's for the dermatopathologist to help parse out for the clinicians. So, as I mentioned here, the Monroe microabscesses are more superficial, neutrophilic collections within the stratum corneum here, and then you see an example here. Whereas I said that the spongiform pustules of Kogoge are lower, a little bit lower down, but it's still the same thing. It's still collection of neutrophils. It's just deeper down towards the stratum spinosum. What are the different subtypes of psoriasis? So you should know that there are major subtypes of psoriasis. There can definitely be some overlap clinically, but the classic is psoriasis vulgaris. It's a chronic plaque-type psoriasis. You can also have guttate psoriasis, which is an abrupt onset of small pink scaly papules, and it's associated with strep infection more often than not. You see it in young patients after strep infection. And interestingly, on pathology, guttate psoriasis does not have very robust psoriasiform epidermal hyperplasia. It's got some other things, which we'll talk about, which can help you make that diagnosis. Pustular psoriasis is where you actually see subcorneal pustules. Reiter syndrome looks identical to this. So, and that's an infection basically. So if you see some type of pustular eruption, you should definitely want to make sure that you're going to rule out Reiter syndrome or keratoderma blenneragicum, which can look exactly like psoriasis, but presents on the palms and soles. And it's usually due to some gonorrhea or chlamydia infection. Reiter syndrome is also known as reactive arthritis. We're trying to get away from the eponym here. Erythrodermic psoriasis is presenting as generalized erythema and fine scale. And inverse psoriasis is mainly defined by where it's located clinically, so intertriginous and flexural areas. Now, guttate psoriasis, they say looks like raindrops, hence the name guttate. So you can kind of see that morphology of these fine papules coalescing into plaques with some fine silvery scale on top. They may Kebnerize, so that means that if you've got mechanical stimulation along the rash, it can actually cause development of new lesions along that mechanical stimulation. So you'll see some linear patterns or geometric patterns. As I said, guttate shaped like or resembling drops. And as I also just mentioned, it may follow strep infection, especially in children or young adults. So guttate psoriasis has some epidermal hyperplasia, but it's nothing that you would just jump to say looks, like classic psoriasiform hyperplasia. So What you're going to want to look for is perikeratosis with neutrophils. That's going to help you figure it out. Now, this is a very robust example of diffuse perikeratosis, but often you'll just find intermittent mounds of perikeratosis, similar to what you would see in Pityriasis Rosea, except you're going to look for those neutrophils within the mounds of perikeratosis. You'll also want to look for other areas that make you think about psoriasis, so hypogranulosis pretty diffusely, as well as some dilated capillaries within the dermal papilla. You can still have spongiosis that is usually present in guttate psoriasis, and some perivascular lymphocytic inflammation without a lot of eosinophils. So if the clinical story fits, and you get this histology, rule out guttate psoriasis, then you should say that you highly suspect guttate psoriasis. Overlying perikeratosis and neutrophils are the classic, but like I said, you can just have little bits and pieces of mounds of perikeratosis, but you got to see those neutrophils for it to be classic. If you just see mounds of perikeratosis without a lot of neutrophils, and maybe you see some red blood cell extravasation here and just some mild spongiosis and preserved granular layer, you can think about Pityriasis Rosea. Again, less epidermal hyperplasia, so don't be looking for pure psoriasis and guttate psoriasis. Don't be looking for pure psoriasiform hyperplasia, rather, in guttate psoriasis. Superficial perivascular lymphocytic infiltrate is nonspecific, but that's what you see. And the differential diagnosis is going to include things like erythrodermic psoriasis and Pityriasis Rosea, as I mentioned. So here is a great example clinically of pustular psoriasis. What I like about this picture on the left is it just shows you some scale sitting on top of a base of erythema. In fact, that's how you usually see pustular psoriasis present. You usually do not see these beautiful pustules unless it's under a thicker stratum corneum, say the hands and the feet. So on the normal trunk and proximal extremities, you'll usually find that the pustules have already ruptured, and now you've just got this diffuse skin. You might find a few pustules throughout, but more often than not, clinically, I've seen patients that have just presented with this fine scale. So you should be able to recognize that and suspect pustular psoriasis if you do see that. And this is why a biopsy is so important. So on pustular psoriasis biopsies, you should want to try to find a scale to really capture the neutrophilic pustule. And clinically, this happens after withdrawal of prednisone. It can happen after infection. It can be in the presence of low calcium as well. There's a generalized pustular psoriasis called von Zumbusch, where they have more systemic symptoms. Impetigo herpetiformis is a term that is essentially pustular psoriasis, but it occurs in pregnancy. So the term obviously implies infections here, impetigo meaning implying staph infection, and herpetiformis implying a herpes infection, but it has nothing to do with infection. It's all pustular psoriasis. And acrodermatitis continua of Halipo typically affects the distal digits, but it's essentially very similar to pustular psoriasis. So here's an example of pustular psoriasis, more of a plantar involvement. I will mention that I've had patients that are extremely challenging. If you can imagine, this would be difficult to walk, and we've had patients come in that can barely walk, and we've been able to get good control with dapsone. There's some good literature out there that suggests dapsone can act on the neutrophilic pathology here and reduce the symptoms. Classically, prednisone will end up making this worse after it makes it better. So withdrawing from the prednisone will cause flares. Even TNF alpha inhibitors have been associated with this. Some of the biologics, the newer biologics, such as guselkumab, Tremfya, these are going to be considered more effective. So targeting IL-23 is going to be considered a more effective strategy, but I found that even the necessity to combine with biologics in dapsone, for example, to get patients under control. So what do you see on pathology for pustular psoriasis? As I already mentioned, you have perikeratosis, you've got subcorneal pustules, and psoriasiform epidermal hyperplasia. So if you look over to the adjacent sides of the pustules, you can see more classic psoriasiform hyperplasia that will help you separate it out between AGEP, or acute generalized exanthematous pustulosis, which usually isn't going to have as much psoriasiform epidermal hyperplasia. The other thing is, usually in pustular psoriasis, you're not going to find a ton of eosinophils, whereas in acute generalized exanthematous pustulosis, um, you will see more eosinophils, not only in the dermis, but in the epidermis and even in the pustule itself. Another example of pustular psoriasis here, you can see the intraepidermal neutrophils. And again, you can see more intraepidermal neutrophils here in pustular psoriasis. Sometimes you can get involvement of the mucosa even. Moving on to erythrodermic psoriasis. So this actually doesn't look very much like psoriasis, right? It looks like erythroderma. So greater than 90% of the body is erythrodermic here. And you may not be able to tell that this is psoriasis at all clinically. So we have a long list of things that we associate with erythroderma. You can think about Sézary syndrome. You can think about whole body allergic contact dermatitis or systemic contact dermatitis. You can think about a severe drug reaction. You can think about Pityriasis rubra-pilaris, obviously erythrodermic psoriasis, as we're talking about. There are a whole host of different clinical scenarios where you could see erythroderma. So it's important to do a biopsy just to kind of see what pattern you can see. Now, unfortunately, with erythrodermic psoriasis, it makes sense with the clinical pathologic correlation. You're not going to see much that looks very similar to psoriasis. But you can see some focal parakeratosis. You can see some slight epidermal hyperplasia. You can see scattered neutrophils. So I think if you're seeing neutrophils and slight epidermal hyperplasia, focal parakeratosis, and you know that the patient's erythrodermic, that you cannot rule out a erythrodermic psoriasis. And that's the most important thing. Is the first job in dermatopathology is to rule out some things, because at least if you rule out something, the clinician was suspecting that you did part of the job. And then if you can nail the diagnosis, that's going to be the bonus for sure. Another example of parakeratosis, just focally in a subcorneal pustule. If you had no clinical information whatsoever, there's no way you're going to call this erythrodermic psoriasis just by looking at the pathology. You need to know the clinical, because right now this looks more like subacute spongiotic dermatitis. Inverse psoriasis, it's all about location. So here it involves under the breasts or in between the buttocks or even around the nipples or under the arms and the axilla and the groin region. So you have to know the location. And I've had patients present with underarm plaques that look like Haley clinically, and our clinicians did biopsies and it comes back looking more like inverse psoriasis with no suggestion of Haley whatsoever, but shows classic psoriasiform dermatitis. So biopsies are always going to be key to try to match the clinical. The other thing with inverse psoriasis is that you do still have sharply demarcated plaques. Now, of course, your number one differential diagnosis is anytime you have intertriginous is going to be intertrigo, which could be due to irritating substances or just the chronic friction or allergic contact dermatitis by something such as deodorant in the axilla. Of course, fungal infections, also very high likelihood to have involvement in the intertriginous area. So you got to rule all that out as well. Inverse psoriasis, you're going to see some regular epidermal acanthosis as well as neutrophilic microabscesses, capillary ectasia, and the papillary dermis and superficial lymphocytic infiltrate. So it's essentially psoriasis. It's just about the location clinically. Now, I mentioned the TNF-alpha inhibitor-induced psoriasiform eruptions, and that is where you're going to see psoriasis, but this is the exception. So where you see eosinophils in the dermis, it can be because of that TNF-alpha inhibitor actually paradoxically causing a worsening psoriasiform dermatitis. You'll find eosinophils and you'll also find plasma cells. Psoriasiform reactions to TNF-alpha inhibitors will involve even the palmo and the plantar areas. You'll see palmoplantar pustulosis. That often develops as a complication of the infusions, TNF-alpha inhibitors such as infliximab. And this is on the right here, you can see an eruption of a plaque-type psoriasis in the patient receiving infliximab. So at that time, you should just switch to a different biologic and hope to relieve them of this reaction immediately. I mentioned reactive arthritis. As we remember, how do we remember reactive arthritis? It's the triad of urethritis, conjunctivitis, and arthritis associated with a GI or a GU infection. Common causes include chlamydia, as I said earlier, as well as Campylobacter and Yersinia. So the way people like to remember it is can't see, can't pee, and can't climb a tree. That's reactive arthritis triad. Predominantly affects young men, and 80% are positive for the HLA-B27 variant. Cutaneous lesions in 50% of patients will present as balanitis circinata, such as around the penis, keratoderma blenneragicum, as I said, on the palms and soles, and then pustular or psoriasiform lesions as well. So I remember a case during my residency where the patient came in and had these psoriasiform papules and plaques on the hands and feet, and actually throughout the whole body. It was very striking. And it eventually was that she had a GU infection with gonorrhea or chlamydia, I believe. And she was treated with antibiotics, proper antibiotics, and her skin lesions went away eventually. Biopsy showed psoriasiform dermatitis. So just more examples of that psoriasiform dermatitis and reactive arthritis. It can be pretty striking. More examples of the psoriasiform papules and plaques on the hands, for example, here, and on the feet. And the patient I had in residency looked exactly like this. Some more examples of it affecting the penis here with a balanitis circinata. And on pathology, you're going to see a psoriasiform dermatitis as typically described. Maybe not as much epidermal hyperplasia in this picture here, but this is not always going to be, it's going to be more classic in many cases as well, depending on how evolved it is. Another example, psoriasiform dermatitis with a lot of neutrophils. Seborrheic dermatitis is kind of an overlap between spongiotic and psoriasiform. You've heard of the quote SIBO psoriasis. So if you think about seborrheic dermatitis, there's a lot of overlap with the psoriasiform dermatitis, but you can get some spongiosis too. It doesn't look like classic psoriasis on biopsy, but it's got some features, psoriasis here. Now you see a baby with really robust seborrheic dermatitis. You would need to worry about a Langerhans cell histiocytosis if this patient was not responding to usual treatment of seborrheic dermatitis. Some more really robust seborrheic dermatitis, you definitely would include in your differential things like psoriasis and irritant contact dermatitis. You're going to put a lot of things on your differential here in a baby if they're not getting better as well. Unfortunately, fungal infection, mycosis fungoides, so many things can actually present looking exactly like this. Even Langerhans cell histiocytosis can present in the groin region. So pediatric dermatology is very challenging, but just to remind everybody that seborrheic dermatitis can present with this really robust inflammatory reaction. And here's our classic young adult to middle-aged adult male with a seborrheic distribution inflammation here across the cheeks and nose, onto the forehead as well with some scale. And so luckily we have ketoconazole, we've got some cyclopirox shampoo, we've got hydrocortisone and protopic, things that we can use to really lessen the side effects of seborrheic dermatitis. Now, what do you see on histopathology? It's really a combination of psoriasis and spongiotic dermatitis. So you can see focal parakeratosis with the predilection for the follicular ostia. And so this is that, you may have heard of shoulder parakeratosis or follicular lipping. And so here you see shoulder Perikeratosis, you'll find that the perikeratosis is more pronounced around the follicular ostia. You'll see some occasional pycnotic neutrophils, plus or minus crust present within the perikeratosis, some moderate psoriasiform acanthosis and mild spongiosis with focal exocytosis of lymphocytes. You'll see some sparse superficial dermal mononuclear infiltrates as well. So here is a very classic example of seborrheic dermatitis on biopsy. You can see some hyperplasia of the epidermis. You can see lymphocyte exocytosis, spongiosis. You see perikeratosis around the follicular ostia here. Maybe a little bit of keratin collection and debris within the base of the follicular ostia. So just by looking at the biopsy alone, it's going to be difficult to say seborrheic dermatitis unless you have some clinical. If they tell you that they're concerned about seborrheic dermatitis on biopsy or they're suspecting it, and you get this biopsy back, then you definitely can't rule it out. You definitely would rule it in. And then the other thing is if they show you something on a test that looks like a combination between psoriasiform hyperplasia or spongiosis, or it looks like it's coming from the scalp, and you see this lymphocyte exocytosis and perifollicular lipping, if you look through the answer choices and nothing else fits for classic and they have seborrheic dermatitis, then that's the answer you should choose. Because I feel that if this were a test question, they would put other things that you would be able to say, well, that's not classic psoriasis, or that's not classic like mycosis fungoides, or that's not classic Pityriasis rubripilaris. They may put things there, guttate psoriasis, for example, that you'll be able to say, well, these aren't classic. So then you go through and you say, well, the only thing that's left that this could be is seborrheic dermatitis. So in a testing situation, that's probably how they would expect you to be able to make the diagnosis, by ruling out everything else. Now, usually, I mentioned mycosis fungoides. Now, what would argue that this is not a classic mycosis fungoides? Because you can see some halos around these lymphocytes, so you might be thinking that. But there's a lot of spongiosis around here, and typically in your classic test questions, they're not going to put a bunch of spongiosis in the epidermis on mycosis fungoides, and they may put mycosis fungoides as an answer choice, but leave everything else out. That could be confusing with that. So if there was ever a clinical concern for mycosis fungoides versus subderm, which I've had before clinically, or on the rule out, I've had that clinical concern, then I'll just do some stains to highlight the lymphocytes. I'll make sure that there's a mix of CD4 and CD8, that these are not predominantly CD4. I will make sure that they retain CD7 well. I will make sure that the ratio of CD4 to CD8 is not greater than 10:1. And I may do CD2 and CD5 to make sure they're retained, just to quiet the clinician's fears that it's not mycosis fungoides. If the patient has a history of mycosis fungoides, it'll often bring up that clinical scenario of, is it subderm or is it worsening of their mycosis fungoides? So just as a side discussion there, that's an important consideration to make when you do see intraepidermal lymphocytes. But for classic testing purposes, if you saw mycosis fungoides, you would have a lot less spongiosis on a classic exam question. And this, to go back to seborrheic dermatitis, you're also going to see that lipping and perikeratosis, which you wouldn't often see in mycosis fungoides as well. So seborrheic dermatitis is just really, like I said, a mixture of hyperplasia with some spongiosis and perifollicular lipping. So just be aware of that as an entity that you would be expected to potentially get right on an exam by ruling out everything else. Now let's go to acute generalized exanthematous pustulosis. I mentioned this earlier, that it often is confused. It's confused on histology a lot with pustular psoriasis, but clinically, the story is usually that the patient got some type of drug or antibiotic 2 days before they had eruption of these very fine papules throughout the face and the body. And so AGEP, as we call it, it's easier to say, is an acute febrile drug eruption characterized by numerous small, primarily non-follicular sterile pustules arising within large areas of edematous erythema. You'll see exanthematous drug eruptions that may have a few pustules, but they are usually follicular. Most commonly results from use of beta-lactam antibiotics and penicillin cephalosporins. So anytime you get a penicillin or a cephalosporin, think about that role of beta-lactam. But even macrolide antibiotics and calcium channel blockers, including diltiazem, and even antimalarials that we use to treat our autoimmune connective tissue disease, unfortunately, can all lead to AGEP. So just like any other drug, just like most drug reactions, there's a whole long list of drugs that can cause a similar inflammatory reaction. So AGEP clinically, the time between drug administration and the skin eruption is usually less than 2 days, but it can vary, obviously, depending on the scenario. Characterized by acute onset, fever greater than 38 degrees Celsius. Cutaneous eruption is usually composed of non-follicular sterile pustules on an edematous base. They often begin on the face or major intertriginous zones like the axilla and the groin, and they disseminate over a few hours. They may be associated with burning, pruritus, or both. Leukocytosis can be seen with an elevated neutrophil count. It's very common as well. So just the classic fine pustules overlying some diffuse erythema. These pustules start to coalesce together into plaque with this kind of gold to yellow scale on top. Again, this patient probably got antibiotics less than 2 days before this eruption began. You can see more diffuse erythema here. After a while, the pustules will rupture and the papules will become diffusely coalescing in the plaques. So here you see AGEP on histopathology. You'll find a subcorneal pustule. Again, looks very similar to pustular psoriasis. Irregular psoriasiform hyperplasia, again, that can look very similar. But the key is that you're going to see some eosinophils too. And you got to know the clinical. So if you see a lot of eosinophils and the clinical fits, then it's probably AGEP. So just to summarize on histopathology, the pustular psoriasis with eosinophils, that equals AGEP. Subcorneal or intraepidermal pustules with that mild epidermal hyperplasia. You should expect not to see classic psoriasiform hyperplasia in AGEP, but more of just an epidermal hyperplasia in general. The papillary dermal edema may be present with some spongiosis, superficial perivascular and interstitial infiltrate with numerous eosinophils. Again, if you look up the literature on AGEP, unfortunately, lacking eosinophils does not mean it's not AGEP. So again, this is an unfortunate real world scenario that there are some clinical scenarios where a patient has gotten an antibiotic and 2 days later, they got these exact clinical pustule morphology presentation. And then a biopsy was done of the pustule and eosinophils were nowhere to be found. So just because eosinophils are not found does not mean that it could still not be AGEP, but you do have to say in the comment, there's no eosinophils. So if this is an AGEP, it's not a classic AGEP. And honestly, you could still, if the patient has a history of psoriasis, pustular psoriasis, and it would be difficult to rule that out without the eosinophils. You're going to find necrotic keratinocytes are more common in acute generalized exanthematous pustulosis. And I find that necrotic keratinocytes are actually more common in just drug reactions in general, whether it be an erythema multiform type drug reaction or other types of drug reactions, phototoxic drug reactions, things of that nature. So necrotic keratinocytes can be helpful. Usually you're not going to find a lot of necrotic keratinocytes in pustular psoriasis. And you can even have some leukocytoclastic vasculitis changes, which you're usually not going to see in a pustular psoriasis. All right, so here's another just example of some intraepidermal large vesicles and pustules with neutrophils. And on higher power, you would find some eosinophils there. Moving on to inflammatory linear verrucous epidermal nevus, also known as ILVEN. So ILVEN is represented by erythematous psoriasiform papules and plaques arranged in one or several lines. It tends to be intensely itchy and most commonly arises in childhood on the lower extremities. So here you can see an inflammatory linear verrucous epidermal nevus. You can see this really geometric line going along the extremity here. The clinical consideration would be, are we looking at some type of lichen striatus? Sometimes you can think about incontinentia pigmenti, like the verrucous phase, if you see some type of line that's forming, but this is in actuality an ILVEN. So here are some other differential diagnoses for ILVEN. Linear psoriasis can present this way with Kebnerization. You can have linear porokeratosis, which on pathology, you're going to look for a cornoid lamella. Linear porokeratosis, by the way, is more associated with risk to development of a squamous cell carcinoma. Linear lichen planus can look like this. Lichen striatus, as I mentioned, and incontinentia pigmenti, stage 2. So stage 2 is the verrucous stage. Stage 1 is the vesicular stage. Stage 3 is hyperpigmentation, and stage 4 is hypopigmentation. Inflammatory linear verrucous epidermal nevus on histopathology, you're going to find alternating para and orthokeratosis that is sharply demarcated with alternating areas of hypergranulosis and orthokeratosis, along with that parakeratosis and hypogranulosis. So as usual, when you have hypergranulosis, you'll have orthokeratosis on top, and if you've got hypogranulosis, you'll have parakeratosis on top. That's generally the juxtaposition you will find in most of dermatopathology. When you think about the alternating ortho and parakeratosis, that's also a buzzword for Pityriasis rubra-pilaris. So the other entity where you hear that phrase is going to be ILVEN. The parakeratosis areas tend to be quite raised. There's underlying hypergranulosis and loss of granular cell layer, respectively. Now, if you think about the difference between clinical Pityriasis rubra-pilaris and clinical ILVEN, usually clinical ILVEN's it's more thick here than PRP. So on histology, if you see this super thick parakeratosis, it's probably not going to be a classic Pityriasis rubra-pilaris. So you got to look for subtle hints, and obviously you have to marry the clinical with the pathology. You can see moderate irregular psoriasiform acanthosis, which you can actually see in Pityriasis rubra-pilaris as well, and variable inflammatory cell infiltrate within the superficial dermis. So here's more examples of ILVEN. You can see that dilated dermal papilla, some intermittent parakeratosis and hyperorthokeratosis. Another example of ILVEN here, not really a specific snapshot diagnosis, but more just to show you some hyperplasia and some intermittent parakeratosis. Now, what I just mentioned in contrast is Pityriasis rubra-pilaris. So clinically, you're going to see these thinner orange to red erythematous papules and plaques, papules even coalescing into plaques, but with these very clear, what we call islands of sparing. So it looks like an orange, the surface of an orange with some areas of the color missing in a way. You can see the scale is not as thick as the ILVEN that I just showed you. And what you'll see on pathology is, let me go back to the clinical summary. So you'll see typical presentation of psoriasiform plaques on the scalp that starts to spread caudally. You'll have these small follicular papules that coalesce to form symmetric orange-red plaques with the islands of sparing, as I mentioned. And important to note that these patients also have waxy palmoplantar keratoderma. If you see waxy palmoplantar keratoderma, you definitely should be thinking about Pityriasis rubra-pilaris, but you should also remember Sézary syndrome, because that can be presenting the same way. So Pityriasis rubra-pilaris and Sézary syndrome both can present with erythroderma. So on your differential, what would help you think about Pityriasis rubra-pilaris versus Sézary? You're going to see these islands of sparing. And compared to erythrodermic psoriasis as well, you'll see more islands of sparing. And with palmoplantar pustular psoriasis, for example, you'll find more pustules, whereas with Pityriasis rubra-pilaris, you'll usually find more palmoplantar keratoderma. You can see here the waxy palmar keratoderma and PRP. Now, what are you going to see on pathology? I'll go to the picture first and we'll summarize with the checklist after that. So what you're going to look for is follicular plugging. Again, this is for your classic PRP. You'll find some psoriasiform hyperplasia. You'll find some spongiosis. You can find some focal acantholysis as well, which is not pointed out here in this picture. You'll find alternating parakeratosis and orthokeratosis, and you'll find some perivascular lymphocytic infiltrate. So putting all those together with the clinical, you should be able to get the diagnosis of pityriasis rubipilaris. Now, to summarize what you're going to see on pathology, you're going to look for the alternating vertical and horizontal ortho and perikeratosis in that checkerboard pattern with irregular psoriasiform epidermal hyperplasia, broad and short reedy ridges and thick suprapapillary plates with focal and confluent hypergranulosis. Follicular plugging, as I said, and superficial perivascular lymphocytic infiltrate. It differs from psoriasis in the sense that you don't see as many neutrophils as you see in classic psoriasis. The suprapapillary plate thinning is not that prominent usually in a classic PRP. You can find areas of hypergranulosis instead of diffuse hypogranulosis in psoriasis. The blood vessels are quite normal usually in classic PRP. And like I said, you can have plus or minus acantholysis between the keratinocytes. Another example of some hyperplasia, some alternating para and orthokeratosis. Again, just some more examples of that checkerboard alternating. So you've got para and ortho, and para, ortho, para, ortho, para, ortho, para, ortho, like that. So it's not a perfect checkerboard. You're not going to be playing a game of checkers on the stratum corneum. And you should not rely on this perfect checkerboarding pattern whenever you're trying to make the diagnosis on a test. Just put all the features together. And if they give you some clinical information, that will help. Also, they'll give you other answer choices you can rule out and say that's not classic, forget any of those. So what you're going to be left over is a pityriasis rubipilaris. All right, moving on to Pityriasis rosea. This is a rash that's most common in children and young adults. It's seasonal, usually associated with viral infections such as HHV 6 or 7. You've got some round to oval thin salmon colored scaly plaques on the trunk, necks, and proximal extremities. The buzz phrase is Christmas tree pattern. It follows the lines of cleavage on the back. The herald patch is first. It's the largest plaque, and then you'll get the eruption of some other small papules and plaques. So here's the herald patch forming, and then this Christmas tree distribution here. As you see, it's shaped with these diagonal lines of distribution on both sides of the back. Clinically, it's often in young people as these fine papules and plaques with overlying cigarette paper-like scale, very thin scale. Here you can see more of the very fine cigarette paper-like scale. Some more examples of PR. Now, what are you going to find in histopathology? So it can be pretty subtle. Now, this is obviously pathologic, but what I mean by subtle is that it seems nonspecific, and you have to put it together with the clinical suspicion in the scenario. But you'll find some acanthosis and spongiosis. You'll find some lymphocytes that can be exocytosed into the epidermis. You will see mounds of parakeratosis on most cases, depending on where the biopsy was done. If it was biopsied in a more scaly area, then you'll find mounds of parakeratosis similar to like a guttate psoriasis, but those mounds typically will not contain neutrophils. You're going to look for extravasated red blood cells within the dermis around the vessels, and you'll find the perivascular lymphocytic infiltrate. So you'll put together all of this and you'll put it together with the clinical, and then you'll say, you know, PR is definitely possible. If they say rule out PR and you have some mild spongiosis and you have focal extravasated red blood cells and a mound of parakeratosis without neutrophils, it's pretty much PR. There's no way to rule it out at that point. In fact, you should rule it in strongly. Here's an example of a mound of parakeratosis. This is mostly retained keratinocyte nuclei, not neutrophils. Sometimes it can be hard to tell if there are neutrophils in the perikeratosis or not, depending on the cut, depending on how small those nuclear fragments of the keratinocytes are. So if they put guttate psoriasis and PR, then you're going to start looking for other things that might point you towards guttate psoriasis versus PR. So gut-tape psoriasis, you'd expect a lot more hypogranulosis and maybe a little bit more psoriasiform hyperplasia. You'd expect to see less extravasated red blood cells, and you'd expect to see more dilated vessels in the dermal papilla that are directly abutting the basement membrane. So here you have maybe a few dilated vessels, but they're not really directly abutting the basement membrane. Still, that's not going to be diagnostic. What's going to be diagnostic for PR is the clinical fitting well with cleaner mounds of perikeratosis without neutrophils and the extravasated red blood cells. Clear cell acanthoma is mentioned in the psoriasiform reaction pattern because it looks a lot like psoriasis. Now, it's not a rash, it's actually just a single lesion. It's a fairly common benign tumor that presents with solitary, sharply delineated red nodules or plaques on the legs. Many have thin crust with moist exudate. They may have a collarette at the periphery. You'll see why they often do have some crust and exudate. I'll show you that there's a nice clinical pathologic correlation here. So here you can see a single lesion and see these areas that are a lot more red. That's where the dilated vessels are really close to the epidermal surface here. And so if you scratch this off, or there's a little bit of trauma, it's easy for the serum and the blood to leak out and develop a crust or some kind of a serum drainage, a moist exudate coming from the clear cell acanthoma. Now, clinically, if the clinical differential of pink to red papule is quite large in dermatology. So oftentimes we rule out clear cell acanthoma because it looks like this, but you might rule out basal cell, rule out amelanotic melanoma, rule out pyogenic granuloma or lobular capillary hemangioma. There's a lot of things that can clinically mimic this. You might even get other things like rule out cutaneous lymphoma, whole host of things. But before I get to the pathology, it's always a fun teaching point to show the dermoscopy of a clear cell acanthoma. So you see blood vessels are lined up in what we call strings in a grid-like pattern. So you see these kind of beads on a necklace almost, and they're just easy to spot very clearly on dermoscopy. And the clinical pathologic correlation of that is these blood vessels here that are going higher up in the dermal papilla are easier to see on dermoscopy. So you'll see these vessels pretty easily, kind of like in psoriasis, it's like the auspit sign, right? So that's where those red punctate areas come from. But what's even more defining of a clear cell acanthoma is the abrupt change between the clear cell cytoplasm here and then the normal purplish cytoplasm that you're going to get. It's like a pink to purplish cytoplasm that you'll see in the normal keratinocytes. So there's a very abrupt demarcation here. And you can appreciate that in this picture as well, the abrupt demarcation. So it's very hyperplastic here. It's very psoriasiform in a lot of ways. And so it looks very similar to psoriasis. And that's why it's presented here in the psoriasiform reaction category. There is a defect in glycogen phosphorylase. And so sometimes they may show you a picture of this and ask you what the enzyme defect is in the keratinocytes. Nutritional disorders are also presenting as a psoriasiform dermatitis, but many times they will, and it'll actually look very similar to psoriasis clinically. So we need to kind of group the discussion of nutritional disorders into this category of lecture. So what are nutritional disorders? Vitamin deficiencies, metabolic disorders such as PKU, zinc deficiency, essential fatty acid deficiency, pellagra, heart disease, biotin deficiency, they all have similar presentations. On the clinical, you'll find some scaly red plaques. And so that is why it looks so much like psoriasis. On histology, you'll have psoriasiform hyperplasia as well. But the key here is a pale upper epidermis. So the classic example they're going to show you is a pale upper epidermis. This is a patient with niacin deficiency, it's known as pellagra, and you'll see this is Casal's necklace pattern here. They often get this kind of a photosensitive distribution of psoriasiform plaques. Now, this is a patient that has a Fitzpatrick 4-5 skin type, so the psoriasiform color, the pink color is usually more difficult to see. The erythema is more difficult to see, and you'll actually find more of a hyperpigmentation in the chronic versions of this, okay? You can see more thick hypertrophic plaques here, like lichenified almost looking. And it can even look a lot like lichen simplex chronicus in patients with darker skin tones. On pathology, though, what you'll see, and this is an example of pellagra, this pale superficial epidermis at the top. With psoriasiform hyperplasia, you'll have perivascular lymphocytes as well. So this is definitely a classic digital slide or still shot slide they could give you to be able to make the diagnosis of a zinc deficiency or a niacin deficiency. Any type of nutritional disorder that I mentioned earlier can lead to this pale epidermal cell change with a psoriasiform reaction pattern here. You see this diffuse hypergranulosis, some diffuse perikeratosis, and that pale color change should put you into the nutritional deficiency category. Pallor and ballooning of the keratinocytes, as we mentioned, that's going to be more representative of the nutritional deficiency or metabolic disorder. Now, when you see subcorneal pustules, just as a kind of a summary here, you should be thinking about psoriasis. You should also be thinking about infections. So tinea, impetigo, candida, syphilis, these can all lead to subcorneal pustules as well. What else can lead to subcorneal pustules? You can have acropustulosis of infancy, transient neonatal pustular melanosis, psoriasis, impetigo, an entity called Sneddon-Wilkinson, which looks a lot like IgA pemphigus in many ways. It can look a lot like pustular psoriasis in many ways. And it's defined by intraepidermal neutrophilic pustules. And staph scalded skin syndrome, or even strep scalded skin syndrome, any bacteria that produces a toxin that results in cleavage of the epidermis can result in neutrophilic inflammation here. It doesn't always have to have a lot of neutrophilic inflammation, though. And the other thing is you're not going to find a lot of organisms in the toxin-mediated rashes because it's a toxin. It's not due to the direct growth of the bacteria itself, as opposed to impetigo, where you'd be expecting to see a lot more bacterial colonies in the biopsy. A word about syphilis. So you can imagine how someone would think about a psoriasiform dermatitis here. There is an abundant amount of lymphocytes here, and they seem to be even abutting the basement membrane. So it kind of has this lichenoid appearance to it. So anytime you get this type of reaction pattern, you should be thinking, does syphilis make sense or not? You'll want to go down here to the higher power view of the cells in the dermis and look for plasma cells. Typically, if you have abundant plasma cells and these elongated, what they call long, slender, reedy ridges, or the sexy legs of syphilis, you will actually be needing to definitely do a treponemal stain and correlate with clinically an RPR just to make sure the patient doesn't have syphilis. If you see the abundant amount of plasma cells in syphilis, it should make you think about if you see an abundant amount of plasma cells, you should definitely tell the clinician to rule syphilis out. Even if the stain for treponemal IHC stain comes back negative, you should still consider that this could be syphilis and always put clinically correlate with RPR. The vessels themselves often have an obstructed lumen. That's just something that has been seen before. You can have some scattered eosinophils throughout as well. You can have neutrophils high up in the epidermis and stratum corneum, as I mentioned earlier. And just a word about plasma cells. So plasma cells are commonly associated with multiple entities. And so seeing a lot of plasma cells, you're going to think about syphilis for sure. You're going to think sometimes Kaposi sarcoma can have a lot of plasma cells. Other infections like leishmaniasis and rhinoscleroma can have a lot of plasma cells. Even melanoma and squamous cell carcinoma can have a lot of plasma cells. And that kind of goes back to the fact that body locations, specific body locations, even with just general ulceration, that could be caused by a cancer or even just by trauma to the area, or excoriation, such as the face, the mucosa, back of the neck, the axilla, the breast, the anogenital region, and the shin, often are associated with plasma cells that are recruited. So just because you have an abundant amount of plasma cells does not mean that you have any of these diagnoses to the left. It could just mean that it's a part of the reactive inflammatory infiltrate, and it's something to keep in mind. But when you do see a lot of plasma cells, you should be thinking if any of these other entities make sense in the clinical context. If you also have a really abundant amount of plasma cells in an unexpected location and they're collecting in abundance, you should be making sure the patient doesn't have some type of myeloma, multiple myeloma, or some type of plasma cell based hematologic malignancy that's going to lead to cutaneous deposition of abundant plasma cells. A word about granular perikeratosis. Granular perikeratosis is a type of rash that will develop in the intertriginous areas. You're going to see this kind of brownish to goldish to yellowish color papular coalescing into plaques. They'll often be induced by friction or occlusion, and there's a defect in profilaggrin processing. So if you think about profilaggrin, you're going to be thinking about ichthyosis vulgaris, you're going to be thinking about atopic dermatitis as well. But there's been an association with the granular perikeratosis. There's a defect in profilaggrin processing at least. And you'll get this very classic histologic picture here with not only hypergranulosis, but a ton of perikeratosis that has just as much keratohyalin granules as the granular layer does. So it's almost like an extension of the granular layer, but in the stratum corneum. So it's very prominent here, and it's a snapshot diagnosis picture for you. If they said that this was in the axilla and they showed you this picture, granular perikeratosis, that's it. And just a word about porokeratosis. So porokeratosis, this is taken from Dr. Elston's textbook, this snapshot here, but it's cornoid lamella is the common diagnostic feature. You'll see a column of perikeratosis at a 45-degree angle. And here's a good example of that column of perikeratosis or cornoid lamella. And there's a zone between the cornoid lamella that may appear lichenoid or psoriasiform. So if you look here, you'll kind of see this psoriasiform hyperplasia. You may have a loss of granular layer as well, which correlates very nicely with the perikeratosis. So this is classic. Now, if the rule out says rule out porokeratosis, they hopefully would have done a wide shave biopsy and captured the whole epidermis so you could actually see the cornoid lamella, no matter which plane of section the biopsy is taken. But if they don't capture that edge of the scale on a porokeratosis, then it's going to be impossible to find the cornoid lamella, and it's going to be pretty hard to tell them that they have porokeratosis. So the biopsy position is key, and they have to shave through that scale and get underneath it for us to see this classic cornoid lamella. When you do see it, it's exciting if they're wanting porokeratosis. Now, you can have incidental cornoid lamella in a lot of different entities, such as actinic keratosis, even squamous cell carcinomas. So just seeing a cornoid lamella by itself with nothing else is highly supportive of porokeratosis, but you could still see like an adjacent pre-malignancy or even malignancy. And your diagnosis of that actinic keratosis or squamous cell should trump your diagnosis of a porokeratotic-like change adjacent to that. All right, so that is it for the content for this lecture. And I've already done a lecture on interface dermatitis and spongiotic dermatitis. So this was to complete kind of the common basic epidermal inflammatory reaction patterns.